Well, I think most of you know me. Maybe the new members don't. New members, new employees. I'm Melissa Calkins. I'm the Director of Clinical Quality. And I come to education for all of the clinicians to teach about documentation and regulation. So I know that you guys got my spiel like 2 months ago, it feels like, about documentation. So this is really just going to be a repetitive but high-level overview and really short, okay? So if you have any questions, go ahead and stop me all along the way, since there's plenty of time. So the documentation for CNAs. So what is documentation? So it's the validation of the care that you've provided. Remembering if it wasn't charted, it wasn't done. I think I shared last time, but it's a good reminder that all of the care that we provide today, should it ever be needed in court, whether it's our own personal injury or a complaint from a patient or their family, the soonest it would be heard in front of a judge is 2 years from today. So it's just a good reminder that when we chart, we really want to document what happened, what was said, if it was a complex situation, and what we did and the response of what we did. It communicates the care of the patient to the IDT team and others. So our facilities get our charts, our physicians use them, and of course the quality team looks at charts all day long. Supports the patient's eligibility for hospice care through your detailed observations. So as a reminder, anything that you chart can either help or hinder a chart. It can help because our nurses and our doctors are portraying in their documentation that the patient is dying from some terminal disease. So when your documentation helps and says things like the patient's very weak or short of breath or can't speak because of pain, or they're no longer speaking because they're really isolated, that helps paint the picture of hospice and that the patient is terminal in their disease. And I'll go more into what I call happy charting, which we say hinders a chart because our reviewers think that patients that are happy and eating and moving around aren't dying. So we have to be tricky in our documentation and focus just on the hospice picture. So some basic documentation guidelines. Again, if you didn't chart it, it wasn't done. It's important to be objective, observations without documenting personal bias or opinions. Describe, don't label or diagnose. Use only abbreviations approved by Hope West. Have you put that out yet? Oh, maybe, yeah. I will, after we're done here, we have a new policy. So we obviously have had an abbreviation policy since we opened in 1993, but we seriously hadn't updated it for many, many years. So it had some old abbreviations and just some silly ones that we would never use, like just FOTH for father. Oh yeah, G for good. Some weird random things so we updated it. We used JACO and Tabor medical dictionary, right, to research all of the ones we chose. So if there's something in there that you see is used by all medical fields and we just didn't get to it, let us know and we can update the policy. But we think it's a really robust list, and so becoming familiar with it is huge, and so I apologize, but using only what you see in there and then being careful with shorthand. So things like SMH, we all know what that is, but a person reading the chart might not know it's a hospital, and it's important to say that they went to the hospital. Same with when we use the acronyms that we've given nursing homes and facilities. Like, what is the one that I saw the other day? Oh, Center for Foresight. Yeah. CFC, I don't know even. It was weird. I was like, where did they go? So, yeah, just a good reminder to use the appropriate abbreviations. Be consistent, clear, and accurate. Always use correct punctuation and spelling. So we always want to be professional with our grammar and our punctuation. I am the worst person with periods, as my team will allude to. My PowerPoints all have to be fixed for periods. But this is mostly important of when you guys are using that talk-to-text feature. So making sure that you read it before you finalize your document, because Siri does some really strange and inappropriate things. and making sure that your documentation shows your professional side. And then if you notify the nurse of unusual findings, include it in your entry. We have, Justine's not here. So we've been messing with the CNA form in our EMR task force, trying to make it easier for all of you to do your job. And that's one of the fields that we made in a narrative box rather than a check box. So what you've reported to the nurse. So it will be a change for you to need to type out what you've, or talk to text what you told the nurse.
So if there's no report, you say you're going to contact the nurse this day, or?
Nothing unusual to report would be what you would say if you didn't have anything. So objective documentation. So on the previous slide, I said it's important to be objective, so without bias. So expressing or dealing with facts or conditions as perceived without distortion by personal feelings, prejudices, or interpretations. So you guys are with our patients in some very intimate situations, whether it's alone with the patient or with complex families. So we want to document what we did, right, and what happened in the visit for our own protection, but also some of it paints a picture. So these patients that I've seen, some of you CNAs in my complex case reviews, have a lot of stuff going on with APS, mental health with the family, alcoholism, drug diversion. So it's important to capture those if you find yourself in a complex instance with them. But we want to make sure we do it without bias. When I say bias is where it would be something that we perceive. So she may be a raging alcoholic, but we don't want to say that. We have to say things with tact, because that is my perception. That is my judgment that she's a raging alcoholic, even though it might be obvious. So examples of non-objective would be, he went to the door because he wanted to see outside. Did he tell you he wanted to go outside, or is that, see, that's just a simple one. Do you know that that's why he was going, or was it unpurposeful? Stubbornly, she did not ask for help. So stubbornly would be a judgment call that she was being stubborn. She pulled away as usual when I tried to help her stand. So saying as usual, so maybe the reason she pulled away today isn't the usual reason. Does that make sense? Like before it might have been fear, but today is pain, things like that. Patient's daughter is drunk and acting crazy. So again, judgment of behavior. It's clear that that's the behavior, but we want to be careful how we document. So changing those around would be patient went to the door stating he wanted to go outside, so if that's what he told you. She did not ask for help prior to standing and appears unsteady. She pulled away as I tried to assist her in standing, so just a simple sentence. Patient's daughter smells of alcohol and is not responding to attempts at redirection. So that helps paint the picture that this daughter was not helpful in the visit and that the patient's possibly unsafe, but it's not our judgment or our bias. So observations. This is kind of a repeat from my last PowerPoint. So you've all seen it before. But so observations entail subjective, what the patient said, and objective observations that you see, hear, smell, and feel. And obviously, like I just said, unbiased. Some important observations that you guys notice or that you get to witness because you are in these intimate situations is the level of function. So you see more of their level of function than the nurse would because you are actually actively taking them to the restroom or the shower or helping them reposition. So not only are you telling your nurse and perhaps she's documenting it, but you guys also documenting it is helpful. So when they're unsteady or weak, no longer eating, no longer ambulating the way they used to help in the shower and now they don't, things like that, change in level. And what does their ambulation look like? So again, slow and steady, walker, cane, wheelchair. What are they saying? Are they nonverbal? So are they saying things that are signs of depression? Are they saying things that are signs of pain? Are they now mumbling and you can't understand them? What are their facial expressions? What's their body posture? This is one of the important ones that really help is when we have dementia patients that no longer have truncal support. It truly helps to say how ill and frail they are when they can't sit in their wheelchair straight without pillow support. If you have to assist them in the bathtub, I don't know what it's called. Mm-hmm. Yeah, it's really, or
Leaning to the right.
yeah. So even when they're ambulating, if they're a wall surfer and they tend to lean.
Can't use the word listening.
Yep. What does their skin look like? What does their breathing sound like? What's their bowel movements or urine look like? So if you smell a foul odor or they're having increased diarrhea, increased incontinence. And then what interventions for symptom relief did you provide? So not only was the patient pre-medicated so that you could provide your cares, but the things like hot cold compress, warm blanket, titrated oxygen, cool fan, these are things that a layman doesn't know, and we really want you to take credit for the skills that you have. So I always make the joke that my husband, who's the security guard at the front desk at the care center, wouldn't know what a hot blanket would do if it hit him in the face. Like, really, hot blankets can provide comfort to someone who's scared. They can provide pain relief. The weight can provide somebody who's agitated a calming sense. And these are things that you've learned either in practice or in school, and really we think it's important for you to take credit for what this patient requires in order to, I'll put quotes up before I even have a word. I lost it. So when we say the patient's comfortable, patient's resting peacefully, why? Because we did these things. And they require these things and wouldn't receive these things if hospice wasn't involved. So, it's really big. Documentation focus. So, like I said, you guys likely spend more time with our patients than any other clinicians in the field. And so your documentation greatly supports the patient's eligibility for hospice. So a patient to be eligible for hospice has to have a prognosis of less than 6 months. So a patient who's really ill, that's easy to define and that's easy to detail in your documentation, but we have patients who've been here 3 or 4 years and it's hard. And so that's why we want to make sure we capture the good stuff, which we call doom and gloom, and avoid the happy charting, which would tell a reviewer that the patient doesn't need hospice and isn't dying anytime soon. Because we have no crystal ball, and our physicians do the best they can at prognostication based on the medical judgment, and so we have to help support them in that. So things that help with eligibility: changes in condition or ADL level of dependence, change as in decline. So we want to be careful that we're not talking about they used a walker and now they walk fine. So we want to talk about the opposite. They used to walk and they use a walker now. Significant statements made by the patient, family, caregiver, facility staff, or IDT. So statements like that they're really seeing a change, that they're different, that they're more sleepy, more weak. Change in level of alertness or mood, poor intake or appetite, and abnormal bowel elimination. So you'll see how these are all things that identify a patient as not doing well, so that it helps paint that picture that they're probably more likely than not going to die in the next 6 months. So more focus would be changes in skin color and condition, signs or comments of symptom burden, so trouble breathing, pain, nausea, diarrhea, vomiting, exhibiting poor ability in ambulation, turning, positioning, range of motion, simple wound care. So we like to see even just a minimal skin tear or bruising. It helps really paint that picture. I mean, I probably have skin tears and bruising too, so it's a ridiculous thing that it's so helpful, but it truly is really helpful. Social support and or education and their response to care. So the difference. So happy charting versus doom and gloom. So we love when our hospice patients are able to be comfortable, happy, and positive. That's what our mission is. That's why we went into the clinical field. And I don't want you to feel like you can't take credit for when they are. I want you to be able to say that they enjoyed your visit, and at the end of the visit they were resting peacefully, or they told you they enjoyed the shower. But since the primary focus is supporting the physician's prognostication, we do need to focus more on the doom and gloom and not the happy charting.
Melissa, could you say something like patient and family are grateful for caregiving? You know, like
Yes.
say that they smiled all over themselves.
It's actually perfect to say when a patient and family are telling you that they feel like mom is doing better because of hospice, that they're grateful for the care, they don't know what they'd do without you, because that helps us say that, because even the regulation says, and all of the studies say, patients do better with hospice involved. They actually look better after hospice involvement, and so we know it as a fact. And so it's helpful when the statements are in there that we can use that legal argument and say, as evidenced by the CNA on 2.2 said that. So I'll go into a little bit of the how to doom and gloom chart. So utilizing the hotspots. The hotspots are in your packets, and I think they're also in your laminated cards. They focus on the signs and symptoms that are related to the burden of their disease. So based on their diagnosis, what are the things that you would be seeing that would be helpful to chart? And then finish the thought. So are they comfortable, enjoying your visit, loving the shower, but it exhausted them? Have they not had any visitors since your last visit? So you don't always have to chart this way, but it's helpful if you do. Don't feel like you need to write a novel, but if they truly are expressing that nobody has seen them, they haven't had their nails painted in forever, they weren't bathed, again, unbiased, so making sure that we're not blaming the facility or caregivers for unbathing, but just say patient hasn't been bathed in the last few days and really enjoyed the visit today and closed their eyes in the shower or whatever you're seeing. But we want to avoid things like intake or appetite unless it's poor. So we can check the box that says we provided nutrition. I can't remember what it says exactly, but be careful not to say it was like 2 chicken pot pies. That one was recently, that's why I chuckle, sorry, a nurse wrote that. Because again, our reviewers think if they eat, they're not going to die soon.
What if it's like they're coughing during or choking during?
That's perfect, yes, we want to definitely mention that. That's amazing information is when they're choking, to say that it's not going well.
Yeah, I know, right? But yeah, so don't do intake, but yeah. So,
Right. Yes.
But
Yes. No percentages. So we have found that reviewers don't know what percentages are. So they have denied a chart because a patient eats 30% of their meal. So, and again, what is 30%? So unless you're going to write a novel that, or a large sentence of that 30% of half of a grilled cheese. But sometimes when we just put 30%, it could be a 30% of the ultimate feast at Red Lobster. So it's hard for the reviewer to know, but it's just odd. They have denied charts based on percentages, so we've just cut out that practice altogether. So really asking the facility if you notice on their charting that they're talking in percentages, asking them, well, what does that look like? Are they eating well? And if they are, just don't say anything. But if they're not eating well, it's good to document it. That's a good question.
But it's okay to say they just took like bites.
Yes. So anything that you see in a patient that is not normal behavior. So think of how we eat, how we bathe, how we walk, how we talk, how we socialize with others. Whatever would be abnormal and show that there's something wrong with us, that's what we want to chart. And then avoid extensive patient activities. So if the patient likes to mow the lawn, goes to the mailbox, shovels the snow, just avoid all talk about that. It's just not important. So we call it fluff charting because it doesn't paint a picture other than for us of how the patient is doing.
And what about when they go to exercise? When they go to
So unless you can finish the thought with some sort of doom and gloom, like attempts to go to activities but sits on the side and is only observing, wants to go to activities but can't because of disease, is depressed because they can no longer attend church, things like that. If you can finish the thought with why they went, if it's part of their plan of care. So again, I don't know if I've given you this example. So a patient of ours a couple years ago, the plan of care was to go to Red Lobster for their anniversary. And that is totally fine, and that is something that we're going to provide for them. Or the patient who went to JUCO. But you want to explain what it entailed. All of the care planning, the oxygen, the extra oxygen we had to order, the hour it took to get into the car, the fact that she ordered an entire ultimate feast but only took one bite, and that she slept for the next 3 days. So that's what is finishing the thought. So we tend to avoid that happy charting unless we can finish the thought of saying how it was very important to this patient that this occurs and that it was a burden for them. Discretionary words such as stable or slow decline. So again, we don't have a crystal ball, so we don't want to say things like stable or slow decline because really we aren't able to say that because they could have a major decline tomorrow. A lot of our patients who are stable or slow decline are heart disease or COPD, and they're at risk for exacerbations and sudden death. So that's why I call them discretionary words. And reviewers like to use that as their headline, patient stable and appears custodial. So our patients obviously are custodial. They're in hospice, they're elderly, they're in end of life. We need to paint the picture that they're custodial that requires hospice care. So this is the hot spots. So you'll notice it's just with particular diagnoses, the things that you would see. So weight loss, loose fitting clothing, you would see skin breakdown because of the poor nutritional intake, increased fatigue, more sleeping, more assistance with ADLs, meal prep, and home care. You might see their home start to become disheveled. Obviously poor intake if they're having protein calorie malnutrition, and itchy skin. So these are things that you might not know are related to a diagnosis that you can help paint the picture by knowing them, that they're related, and that it's helpful to chart. We would like you to, yes. I think it's important that when you go in, and so that's why we've been messing even with the information box in Suncoast to make sure that we can put the things that you need to know. So what is their diagnosis? Who do they live with? What do they require? What's their, if there's a favorite TV show, I don't know what a nurse would put in there. If you're finding that your boxes now, even now, don't have the information you need to make a visit, let them know because IDT time is part of their time in IDT when they're not talking is to update care plans, and that includes yours. So we encourage you if there's things that need to come off because the patient's no longer on oxygen, no longer can bathe in the shower and is bed bath all the time, or if there's things that you want added, let them know. Come with a detailed sheet and they can just update it in there. So some documentation examples. These were taken out of our charts, and that they were just ones that I really liked and that were helpful in my review when I was getting ready for external audits.
This is charting by CNAs.
Yes, these were in care center or care center, the CNA notes. So very moist, noisy respirations. So this is a patient that we thought had aspirated their food. So that was really helpful because they want comfort care. So we didn't take them to the doctor to diagnose it. We didn't give them antibiotics. We needed to paint the picture that they had aspiration pneumonia and that their end of life was pulled in closer because of that disease or infection. Not responding to questions or commands, very short of breath during activity, and took him some time to recover after sitting down to rest. Very unsteady on his feet today during visit, appears to have bruising to left lower extremity, ambulates very slowly with a shuffling gait, handheld guidance, and at times using furniture to stabilize herself to bathroom about 25 feet. Henrietta seems to be more tired with showering today. Not very talkative today, kept eyes closed during most of visit. John appeared to be moving a lot slower than normal today, and when getting in the shower, the CNA noted that he was gasping for air and had trouble speaking. So all of those really helped paint the picture, even when they were just a small sentence. So you don't need to write a whole novel. As a reminder, who is looking at your documentation? So our physicians use them for recertification. The facilities and other caregivers get our documentation. Internal and external auditors, so the quality team, but also Medicare, and all of these audits that we get. Our payers, so like sometimes Rocky Mountain Health Plans needs to see a chart in order to move forward with paying for hospice. Our IDT members, our families have requested charts, and lawyers and judges in cases like contesting of the wills or patient complaints. Do you guys have any questions? I felt like I had to say something on that last slide, but I don't. Oh, yes. So I just wanted to prepare you. I've prepared all of our nurses. And I think there's been a little bit of a communication in email. I just can't really place it off the top of my head about TPE. Yeah. So TPE is called a Targeted Probe and Educate. It's a Medicare audit that is looking at patients where they find are high risk. So through all of the studying that they do through claims, so just number crunching, they know nothing about Hope West, nothing about the types of patients we serve, our rural area, where we serve. They just know that we have a high level of patients that have a long length of stay. So right now we have 27 patients with length of stay greater than 730 days, and that's what they chose to audit. So they're going to pull these charts and tell us whether or not they think they're eligible. So that will happen first week of March. We were thinking first week of February, but now it's been moved forward, which gives us more time. So just kind of being, just a reminder not to be fearful, because all of our patients are eligible, but knowing that when you document that the doom and gloom stuff that you can add really does help. And so taking the opportunity wherever it is to say extra stuff. Okay, does anyone have any questions now?
There was a couple abbreviations, like I thought I heard we weren't supposed to use the PT for patient, and then like SOB for shortness of breath, but they're in the policy that we can use them, so can we?
Yes.
Okay.
Mm-hmm.
Do you want
Yes.
to include the integrative therapy, like the aromatherapy?
I think it helps not only tell the reviewers who Hope West is, but it also tells what they require to have a quality of life. So that's the hard part, is because I don't want to dampen anybody's soul. I call it moral injury, that I have to tell my clinicians to doom and gloom chart all the time, because you really are in the field to make this patient's life better. And so it really is a tact and a tricky ways to chart in the hospice world. So if you ever have any questions, let the quality department or education know, and we can help you. Because I know it is a burden of me to ask you to flip your soul and chart the opposite way of where your mission is, and our mission. It's just the unfortunate external world we live in.
Are we allowed to name clinicians, like joint visit with
Yes.
Dana, or like the nurse Kate, or like something like that?
You
Yes.
should. You should absolutely identify
Mhm.
who is with you, or anytime you talk to a patient family member or something, identify. If you talked to Kat, patient's daughter, I mean, those things come to play again later on down the road if your documentation ever gets
Yes.
audited, or the daughter's asking and says, I never knew there was a CNA in the home, and she never talked to me about showering mom versus a bed bath or something, but it's in there, right? It's care plan A, it's care plan B. She was there, and she's been present for
Yes.
years.
And you know which daughter. So if the patient had 3 daughters, we would know which one or which nurse. And so we want to make sure that it brought up a good point in my head of making sure you protect your license when a nurse asks you to do something and it's not care planned. You need to make sure that they care plan it immediately and document that they care planned it. So whether you're calling your manager because triage is busy, or I mean not triage, your primary nurse is busy, or you're calling triage, your manager is a nurse also, so they can give you advice. If the patient needs barrier cream and it's not care planned, we need to make sure they document it and then also say instructed by our end, Sandy Joe. Okay? Any more questions? Okay. Oh.
Usually this happens all the time when it's a new admission and the care plan comes out and it has 17 different things for oxygen. Obviously, I immediately tell the nurse to change it. But I'm stuck on that visit, and can I just put not completed NA, NA, NA? Is that okay? Just not applicable?
So is it the patient's on 4 liters and you have 0 to 5 available?
17 options.
Right.
Yeah.
You don't need to put any NA or anything, just leave it blank, not completed, except for the one you chose.
But not completed.
Right. Mm-hmm. Right, Justine?
I
Right.
could be wrong, but if you are ever selected with not completed, you need to put a comment in as to why it was not completed.
Well, only if it's a not completed, so if it wasn't complete, so they need a bath, and it wasn't completed because they were striking out, or the daughter said, I just got mom to sleep, please do not bathe her. Those would be the not completed because. But if it's something like that, where it's because she's not on 2 liters of oxygen, she's on 4, you don't need to say because she's not on 2 liters, because she's not on 3 liters, because she's not on 5 liters. Not right now. We're trying to fix that. We're trying to fix that situation, but.
So the scenarios you just described for a bath, would those not be declined, so it would be not completed?
Well, the choice, you could say declined, but not completed is the choice, right? In
Well, we have
cell track.
not completed or declined.
Oh, there's a decline
So
choice?
if
Oh,
the
yes.
daughter says not bathed, right?
You can put declined, yeah, sorry, I forgot that.
So as declined. So
They just show
I'll
up.
chart things as declined.
Oh,
And when you guys print it out, because I talked to my manager about this.
oh, see, that would be why I never knew it was an
If
option.
it's not completed, it doesn't say patient declined, even though that's what it says on our end.
Mhm.
It looks,
That is very frustrating. So you would have to double document in that sense of hit the patient decline and then write patient declined.
yeah. And so then in my summary, I just always put patient declined shower for whatever reason.
Yes, good.
Under comments, can we say like, facility has their bath day, and a lot of times it'll be a check and change or what? Can I just put down not completed and not our scheduled bath day? Is that okay?
Yes. Mm-hmm.
Just say that, okay.
So when we have to do that, instead of like writing not like why the state or something, patient declined all care, why they declined.
Yes.
And so usually what like our do is check and change, patient declined all care that says for letting the check and change.
Yes. So, Ed, be careful with check and change, because I don't even know what that means. So the reviewer won't know what it means. Yeah. Okay, yes.
I put
Yeah.
care, skin track,
Yeah, okay. I assumed that's what it was, but I don't know. Well, freshen up is a global term, but check and change is not. I love the words fluff and buff, but no, it is not, unfortunately, a approved shorthand. But that's a good, they are our language. Right. And that's a good point. So it is a one or the other. Don't feel like you have to put a comment in every single thing and then also reiterate it at the bottom. If it's all in the bottom, don't worry about the comments above. If it's all in the comments, don't worry about writing a novel in the end. Does that make sense? Somewhere. Keep it simple, stupid, yes. Sweetheart. Oh, that's a good one. Keep it simple, sweetheart, yes.
I'm confused because I made that same question.
Mm-hmm.
If we put over here on top and then on the summary that we have to put in both places. So we don't? I make that same question.
I honestly don't feel like it. Okay, Justine says no.
Handshakes all the way around back there. Everybody's going, no.
Yes.
Because what we put over here, why we should put nobody
Give us some about how the bath.
That's what I'm
Mm-hmm.
saying.
How, you know, just put that picture.
Okay.
So we
Right.
do, because in a sense, we document what we did in the top,
Mhm.
and then in the bottom, we're painting pictures.
Right. So I guess it's it might be a terminology debate. So when I'm saying if it was documented above, documented more than just what the check box is a check.
If you put a comment.
Right. So if you've commented next to bath, you don't have to talk about bath again unless you're going to end the summary of patient is now resting comfortable after bath. Daughter thanked me for visit. Reminded of Hope West availability, whatever you want to put in there. But you don't need to figure out what you said before and say the exact same thing below. Okay. Clear as mud. Okay. Well, thank you. If you guys ever have any questions, let us know. Was there another question? Oh. Oh, yes. Well, I don't know what to say more than there's a policy. There's a new policy. The end. No. So I did let them know when you left that we based it off JACO and Tabor Dictionary and that we put a lot of thought into it. And if there's something you find is missing that is used universally, let us know. But that it's important to use it not only so we all have the same language within the organization, but also that reviewers can fully understand what we're documenting.
Sorry.
Oh, no, I forgot you stepped out.
I don't know if you mentioned the primary RN, PRN.
Oh, yes. So, yes, the very top favorite used one now is PRN for primary nurse. So PRN already has a meaning, and you'll notice through the documentation or through the policy, JACO really recommends that you don't use abbreviations for two things. So not only is PRN kind of silly because PRN has had a meaning for hundreds of years, but we don't want to use something that could possibly mean two things. So PT period is patient. PT capitalized is physical therapy. So there are things like that, but other than that, we've chose nothing in there that has two meanings. So like one that came up yesterday is PU. Apparently providers and maybe some clinicians in wound clinics use it for pressure ulcers. What was the other word it was for yesterday though? It's nothing. We don't use PU for anything, but it meant like 3 different things when I looked it up yesterday. So that would be why it's not in our abbreviation. Okay. Okay. Thank you.
Yeah.